I'm really thrilled to be here, and it's my favorite subject, the diabetic foot and the diabetic foot infection. I don't have any financial disclosures, but I do have some intellectual disclosures. It's been said I've been a guideline committee member of several guideline committee working groups on the diabetic foot and on diabetic foot infection. My employer is Amsterdam University Medical Centers. As you can see here, the ambulances and helicopters are bringing in all the patients because they want to be seen by us in the hospital, right? So what I will say to you today, or what are the take-home messages for today, is infection is a clinical diagnosis. The first-line diagnosis in osteomyelitis is lab, X-ray, and probe-to-bone test. Apply proper culture techniques, know your local pathogens. There's not so much proof for topical antimicrobials. Don't overuse antimicrobials, and consider non-antimicrobial therapies for diabetic foot infections. This is a list of the cooperators that worked on the IDSA International Working Group Diabetic Foot Guidelines for Diabetic Foot Infections in 2023. They're from several parts of the world, except not from Antarctica, and they have different medical specialty backgrounds: vascular surgeons, endocrinologists, podiatrists, infectious disease specialists, radiologists. And most of the things I will talk about today are from that guideline. So first I'll talk about diagnosis. What's important in diagnosis? Well, diagnosis is usually a clinical diagnosis. And it has grades. It grades from grade 1, no infection, to grade 2, which would be inflammation of the skin, the cardinal signs of inflammation: swelling, induration, redness, warmth, pain, pus, and you have no other explanation for the infection, for instance, gout, Charcot, or trauma. Infection grade 3, a moderately severe infection, would be more erythema, so more than 2 centimeters, plus one of the following, the other signs of inflammation, or you have a deep infection, an abscess, osteomyelitis, arthritis, or necrotizing soft tissue infection. As you can see, this is a very heterogeneous group. And for the update of the guideline, we distinguished those with osteomyelitis and those without osteomyelitis, because we felt that they had a different outcome usually, and they needed different type of approaches. This is an example of infection grade 3, so osteomyelitis of the toe. An infection grade 4 would be any foot infection with SIRS, with systemic inflammatory response syndrome, which are the sepsis 2 criteria, and the SIRS criteria are 2 or more of the following. So fever or under temperature, tachycardia, tachypnea, and leukocytosis or leukopenia. So if you have 2 of those, you have SIRS, and if you then also have a source of infection, you'll have a sepsis. And again, we distinguish those with and without osteomyelitis. And why do we do that? Well, because the difference in grades lead to different outcomes. This is a study by Professor Lavery here, South Texas, where they found that patients in the higher infection grade groups had more hospitalizations and more often amputations. So you could argue that we could have used these sepsis 3 criteria, right? The update of sepsis 2 criteria, so no longer SIRS, but Q-SOFA, for instance. And Q-SOFA, as you might know, is they have one of these 3 features, so an altered mental status, so a Glasgow Coma score of less than 15, or a fast respiratory rate of more than 22 breaths per minute, or you have a low systolic blood pressure of less than 100 millimeters of mercury. Now, we decided not to do that because you look at different patient groups then. They have different characteristics. So SIRS has a sensitivity of 86% and a specificity of 79%, and Q-SOFA has a very low sensitivity but a higher specificity. So if you use a Q-SOFA in your emergency room to identify patients with a sepsis, you look at a different population of patients. Besides, the International Working Group Diabetic Foot criteria were already validated in large cohorts, and we don't have any data on the Q-SOFA, but also not on other early warning signs, so the NEWS and MEWS in diabetic foot infections. So we decided to stick with SIRS for the time being. Now, often I get a question by one of the clinicians saying, well, I have a Staphylococcus aureus growing from a wound, so I have an infection. what type of antibiotic should I give? And then my response would usually be, well, we can't use microbiological criteria to define that somebody has a wound infection. And why not? Well, it's because, well, we're born human, right? We go through the birth canal and then we're colonized with bacteria. And within 2 weeks, we're outnumbered by bacteria. So our human cells are outnumbered, say, 1 to 2 or 1 to 10, depending on what definition you use. So we're born as human, but we all die as bacteria. When we're in the grave, we're a bacteria. Unless you find that bacterium in a sterile place, for instance, the bloodstream or the cerebrospinal fluid, then you can use it as a microbiological criteria. But all of our wounds are heavily colonized with bacteria because they like to be in wounds. How about biofilm them? It has been said already in the previous session that you can't see biofilm. This is an electron microscope image of biofilm. You can still distinguish some bacteria in the foreground, the round things, but in the background you see that slimy layer, the glycocalyx that encases these bacteria. And it's important for therapy and for diagnosis, but more important for therapy because our own immune system can't reach bacteria in the sessile phenotype, what it's called, so the biofilm. And in the lab, we usually test our antibiotics to bacteria that are in the planktonic, the free-living form. And there's a difference if you look at tobramycin sensitivity against Pseudomonas. Here in red, you can see the response if the bacteria in the biofilm, so tobramycin hardly does anything with the bacterium. But if the bacteria are in planktonic phase, they're killed off easily by tobramycin. Mind you, those are exactly the same bacteria, but they just have a different phenotype, so they act differently. This is also a striking image, I think. You put a droplet filled with Pseudomonas on a flat surface, let it rest for 0, 12, 24, 48 hours, and then add a pill with antibiotics to it, so tobramycin, colistin, and ciprofloxacin. And as you can see, the bacteria in the planktonic phase, the fresh, no biofilm bacteria are killed off, but the bacteria in the biofilm, the mature biofilm, will grow up to the pill with antibiotics. So can you use PCR techniques to identify your bacteria? Yes, you can, but you'll also notice that you identify different bacteria that might be the real pathogens in the wound. You find more anaerobes, but we don't know what the clinical significance of those PCR results are. So how about the first line in diagnostics in osteomyelitis? Well, in the guideline, we suggest you always take a plain X-ray. What can you see in a plain X-ray? Well, this is not a foot, of course, it's the radius. And what you see here is bone destruction. You can see a periosteal reaction. You can see bone resorption, radiolucency, or you can see sclerosis, hardening of the bone, involucrum, where there's pus in between the periosteum and the bone itself. And you can see a sequestered dead piece of bone which doesn't have any vascular supply. It has a very low sensitivity and specificity, around 50 to say 70%, which is probably just as useful as flipping a coin sometimes, but it's generally recommended to do so because you see other things like probably air in the soft tissue or foreign bodies. You can use biomarkers as well, so sedimentation rate, procalcitonin, and CRP. This is also a study from Dr. Lavery where it looked at what the best biomarker is to distinguish patients with osteomyelitis versus those with just soft tissue infection. PCT, so procalcitonin, performed best, but you can use the other ones as well. But unfortunately, it's unclear if there's an association with outcomes. So if you have a high CRP at baseline, does it mean that you also have a poor outcome, or maybe the outcome is better if you have a lower CRP during treatment? We don't know yet. And then the probe to bone test. With the probe to bone test, you insert a sterile metal probe in the bone. If you feel a gritty hard surface in the bottom of the bone, then you have a positive probe to bone test. Now the test characteristics of the probe to bone test are actually a lot better than an X-ray. but you can combine those three as first-line diagnosis in osteomyelitis. Why? Because it's cheap and is readily available, including in third world countries. The reference standard, however, remains the percutaneous bone biopsy. I'll come to that later on. You can do a wound swab, but it's recommended not to use a wound swab, not in any patient, unless there's no way to obtain another sample. Wound swabs are easy to perform and are non-invasive, but you'll miss anaerobes in your culture, and you'll find a lot more gram-negatives and a lot more skin colonizers like coagulase negative staphylococci or Corynebacterium, Cutibacterium. It's preferred to use tissue samples. They're a bit more time-consuming. They have only minimal risk of injury to surrounding tissues. It's proven safe in large cohorts, and it gets you a lot better microbiological diagnosis than if you use a swab. This is how you take out a piece of the tissue for an ulcer bed biopsy. You debride first, then you rinse it, and then you just cut off a piece of the base of the wound. This is what you do with a percutaneous bone biopsy. You don't biopsy through the wound, but adjacent to the wound, say about a centimeter from the wound. Make sure that you can identify the bone. If not, use radiography to guide your biopsy. Do it through here. You can do it with a Yamashita needle, and then take out small spicules of bone. I use a Petri dish usually to divide the sample because it's sterile. So, I said earlier, why shouldn't you use swabs? Well, this is a French study from northern France where they looked at patients that had osteomyelitis and compared results from cultures from bone biopsy versus those with taken from swabs. And they found a concordance of only 22.5%. So that means that if you target your antibiotic therapy to bacteria that you found in a wound swab to treat osteomyelitis, you have a 77.5% chance that you target the wrong organism. So probably, and that's been proven in a retrospective study as well, the outcomes are a lot worse if you rely on swabs. We just finished the bone biopsy trial in Amsterdam. It was a international and multi-center trial where we looked at the outcomes of patients that were randomly assigned to be treated based on bone biopsy or ulcer bed biopsy. And we looked at remission after 12 months and 6 months, and we found no outcome, no difference in outcome. So that means that as a first line, it might be okay to just use a wound bed biopsy. You don't necessarily have to do a bone biopsy all the time in all your patients. It gives you a lot more reliable results than a wound swab, at least. Now, there's another study going on at the moment in Leeds in the UK, a multi-center trial as well, where they look at bone biopsies versus wound bed biopsies as well. And that's just been finished, and they're stopping the study now after phase 2. It's not continuing to phase 3. That was been announced last week. Another funny study that I thought might be interesting, can I smell Pseudomonas? Most people will say, well, if I can identify patients with Pseudomonas, well, they studied that in Switzerland, where they looked at 13 experienced clinicians who then judged if they thought that there was Pseudomonas in the wound by that blue greenish hue in the wound and a grapefruit-like smell. The reference standard was culture. The sensitivity was really low, but the specificity was high. So that means that you cannot use it to rule out Pseudomonas. But if you see that greenish hue, then it's likely that you have to change your empiric antibiotic regime to a regime that includes Pseudomonas. Now, talking about therapy and antibiotics, I'll move on to therapy. What's important in therapy is that you adhere to the basics of antimicrobial stewardship, also in wound care. This is a statement paper from the EUMA, the European Wound Management Association, which says that if you apply antimicrobial stewardship in wound care, you should work hygienically, only prescribe antibiotics to patients that have an infection, and if you do that, prescribe an adequate antibiotic in adequate dosings and for the right duration. If a patient does not have an infection, then you don't have to treat the uninfected wounds. Had been said in the previous session. But uninfected ulcers do not heal faster if you treat them with antibiotics, and the same is true for venous leg ulcers. So which type of systemic antibiotics should I give then? Is there a silver bullet we could use? Well, there's not, but there's some general guidelines for it. If you have a mild infection in a patient that has not been treated with antibiotics previously, and if you live in a temperate climate, then you can aim your antibiotics at streptococci and staphylococcus aureus. But if you have a moderate to severe infection, if you have a grade 3 to 4 of that classification infection, or if you live in a tropical, subtropical climate, or if the patient's received recent antibiotic treatment or has ischemia, it'd be wise to go for a broader treatment that includes gram-negatives, common gram-negatives, and in case of ischemia and abscesses, possibly obligate anaerobes as well. And then when the culture results come back, you can then target your antibiotic to whatever you find in the culture results. This is a slide that suggests that in tropical and subtropical climates, there's more gram-negatives in cultures. That's based on studies from Pakistan, Tanzania, Turkey, and one from South America. So there are more Staph aureus and streptococci in the Western world and less gram-negatives in the Western world and less Staph aureus and streptococci in tropical climates than and more gram-negatives. So should you always cover Pseudomonas then in your empiric antibiotic therapy? And empiric means that you, of course, you don't know the culture results yet, but you're aiming and hoping for the best. It's not always necessary in temperate climates. It really depends on your local prevalence of Pseudomonas. So, for instance, if you would work in, say, Florida, there might be a higher prevalence of Pseudomonas infections than if you work in New York. I don't know. I don't know the epidemiology of Pseudomonas in the United States. But I do know that in my country, we don't have a lot of Pseudomonas, so we don't treat it empirically, unless it has been previously isolated and or we see that greenish discoloration. So we looked at, we performed a systematic review to all the interventions that had to do with diabetic foot infections, and generally we didn't find any differences in outcomes among antibiotic regimes, except that tigecycline did not do as well as ertapenem and had a lot more side effects. So it's probably not a good idea to give that medication unless that's the only thing that you can give. And there's one sub-study of a smaller study where ertapenem did not seem to do as well as piperacillin tazobactam in a subgroup of patients with a severe infection. The healing percentages were fairly high, so 48 to 90% in case of skin and soft tissue infection. And if you include those with osteomyelitis, the remission rates were 61 to 94%. Now this is a pretty busy slide, but it's one of the tables from the 2012, so the previous version of the IDSA guidelines, where you can look up what kind of options you'd have for empiric antibiotic regimes. So, excuse me. If you have a mild infection, then the second column, you can treat orally for the most part with dicloxacillin, clindamycin, or cephalexin. And then if you have a more serious infection or a moderately severe infection, you usually start treatment IV in the hospital, and then hopefully you can switch to oral therapy as well. This table has a lot of advantages and disadvantages about specific antibiotic regimes. So what's not mentioned in the guidelines are the extensive the extensively resistant gram-negatives, so the carbapenemase-producing organisms, for instance, the class B New-Delhi metalloproteinase producing organisms. We don't know if they're effective in diabetic foot infections, but they probably are. So if you have an infection with those type of bacteria, you might as well use one of these antibiotics, but we're still waiting for proof in the diabetic foot. So how long should you treat then? Well, if you have a mild infection just skin and soft tissue, then you can treat for 1 to 2 weeks. If it's a moderate to severe infection, 2 to 4 weeks. And if there's bone involvement, it really depends on how much bone you resect. So if you have a clean amputation, probably just 2 to 5 days. If you don't do any surgery, or if there's dead bone still left in the body, then 6 weeks. Most of these durations are based on expert opinion, unfortunately. Not a lot of data to support the durations. And there are downsides to antibiotic therapy as well. For instance, you can get damage to the microbiome. You can get Clostridioides difficile diarrhea, or you can get line infections or thrombosis if you give the antibiotics IV. But fortunately, IV therapy is not always required, as been shown in the Aviva trial that will probably be discussed later on in the session as well. A large study, a British study, to musculoskeletal infections in general, including diabetic foot infections, and it seemed that oral therapy was non-inferior to IV therapy for 3 months. Now you could argue, well, that's maybe true for musculoskeletal infections, but not for all the infections. Well, this trial, the POET trial, was done in patients with endocarditis, and even in those group of patients, you can safely treat with oral therapy, combination oral therapy. So even the serious infections can be treated with oral therapy as well. So I'll come back to the take-home messages. So infection is a clinical diagnosis. We use a classification for diagnosis to grade the infection, and based on that, we then decide what kind of empiric antibiotic regime we'll give to patients, or that we admit patients to hospital, or that we proceed immediately to amputation or debridement. The first-line diagnosis in osteomyelitis should be lab, X-ray, and the probe-to-bone test. You should apply proper culture techniques. Please don't take swabs anymore if you still did that. You have to know your local pathogens to adequately prescribe empiric antibiotics. There's not much proof for topical antimicrobials, but I get to that later on. Don't overuse antimicrobials in general, and consider non-antimicrobial therapies.